So we're going to be going over START Triage today. This is the system that we use to triage patients in big mass casualty incidents or big disasters. Pretty much it's our way of very quickly grouping patients into 4 different categories, and this is how, all we have to do to get them there is figure out which category is which. So START Triage stands for simple triage and rapid treatment. It's exactly what it says. We'll, got some 3D graphics that Joe added apparently.
Actually, I borrowed the program.
So START Triage was developed in California in the early 1980s by Hog Hospital and Newport Beach Fire and Marine. It's a rapid approach to triaging large numbers of casualties when you have very few resources. And it's easy to remember, just like everything else in EMS, it's a nice acronym for you to remember. Anybody know who these fellows are? I think they were Joe's first partners. This is Johnny and Roy from the hit show at the time, Emergency. These were some of the first paramedics in California. LA County in California was one of the first paramedic programs in the country, and they wanted to make it a TV show about it. So they wound up using these 2 actors. Joe was the 3rd they were going to pick.
Yeah.
Designed to be used at the scene of a mass casualty incident, an MCI is defined as any incident where the number of potential patients outnumber the available resources that you have. So if you've got, it could be 100 patients, 1,000 patients, God forbid, or honestly, it could be 25, 30 people. It really depends on where you're at and, the resources that you have. A place like this in the metro where we've got, I think a lot of different resources, maybe the number would be a little bit higher, but, if you have some, factory explode out in, maybe Hibbing or something like that, maybe that's a little bit smaller, an MCI could be a smaller amount of people. Triage is generally conducted in what's called the cold zone. If it's going to be like a hazmat scene, there's different zones. Usually the warm and the hot zone are irradiated. So triage for you guys is going to be conducted in that safe cold zone area. There are technicians out there that can operate in the warm zone and do certain kinds of triage and decon, but that's a little bit above our pay grade at this point. So. Again, is there a set number of patients that denotes an MCI? Absolutely not. It's completely subjective and it all depends on the service that you work at. Common types of MCIs, we're looking at terrorist attacks, large fires, air crashes, train derailments, bus accidents with a bunch of people on the bus, building collapses, hurricanes. These things are happening all over the country all the time. Hopefully not a terrorist attack, but we're overdue, unfortunately, so it's going to happen again. This picture I took from the Boston Marathon, which was, that's like a huge MCI. So I've also been to MCIs with just, 20 people, and they consider it MCI. This is the 35W bridge collapse. I'm sure I didn't live here at the time, and you guys are all probably too young to remember when that happened. When that happened, like 10 years ago, I think?
Yeah, I think it was just over 10.
Yeah, so initial patient assessment treatment should take take less than 30 seconds for each patient, which seems short. It's going to feel even shorter, but it's just, our main objective here is to not spend too much time on each patient. We need to get them triaged quickly and get them into the right areas so those areas can be dealt with. Picture of a triage tag here. We're going to be going over what each one of these mean. Usually these have like a little string attached to them, so you can attach it to the patient. We've got our respirations, perfusion, and mentation here. Any kind of contamination right here. Anatomical position, you could make some marks, oh, he's got a broken arm here or cut here or whatever it is. Allergies, all kinds of information about them. And then these tags here, it's hard to see on here, but it's got like a perforated edge. So you could just, if they're going to be like immediate, you can just rip these off, and then that's the last thing. So that way, when these scenes are, usually very chaotic. That way, everybody's got a tag. Hopefully, they don't take it off, and everybody can know which area they should be in. So our different tag systems are gonna be green, yellow, red, and black. Our green tag is gonna be very minor, usually walking wounded. Those are the people that are gonna be walking around. They may have some sort of injuries, but as long as they're walking around and they're alert and oriented, they're gonna be green tag. Our yellow is gonna be a delayed, which means they do need medical attention, but it can be delayed a little bit. Red tag is gonna be immediate. They need to be treated and transported immediately. And our black tags are gonna be deceased. This is gonna feel weird. This is one of the things about, being EMT, being a paramedic, that is an odd feeling. We all got into this to save some lives and treat people, and then you get faced with the situation and you're doing very little treatments, and you're kind of just, you're possibly seeing people with no pulse, and instead of being like, all right, let's start CPR, it's let's black tag them and move on. And it's kind of an odd feeling, but it's just what needs to be done to treat the most amount of people in the shortest amount of time. We don't have the time to be sitting there, doing 5 rounds of CPR and all these meds and everything, because there's 100 other patients that need us. So as long as we can get past that, everything will work out fine. So first things first, we're gonna clear the walking wounded using verbal instructions. So let's say we get into this room, maybe this room's got 20 wounded people in it. A bomb went off, whatever it is, hopefully not a shooting, and you've got 20 people in this room. You come into the room and, all right, everybody who could walk, hang out at this door, and hopefully all the walking people walk out. Those are all green tags now. So now you have all your green tags in one area and you can move on. So we're going to direct them to either a treatment area for the detailed assessment and treatment. Hopefully, if the treatment area is close by, you can just tell them just walk over to that tent. If not, you could also say, hey, hang out by this tree. Everybody who could walk, just stay here by this tree. Whatever you need to do to get it done. So you're going to tag these as green tags. Again, you're going to use your tag system to mark all of them that way. When they're inevitably walking around and leaving that tree, at least they'll still have their tag on. You can tell, where they're supposed to be. Once we're done with that, you should have, all that's left are going to be your black, red, and your yellow tags. So we're going to start checking our RPMs, which I'll be going over right now. So the R in our RPM is going to be respirations. So we're going to start with our first patient. We're going to check their respirations. If they don't have any respirations, we're going to do a quick open the airway using a manual jaw thrust. Usually most of these MCIs are trauma-based, so I wouldn't suggest doing head tilt chin lifts on anybody. Do a quick manual jaw thrust. If they're still not breathing, black tag, deceased. Nothing we can do. If it's restored, then they're going to be a red tag because they obviously had some sort of airway compromise. If we get to that patient and they are breathing, if it's above 30, they're going to be a red tag. If it's below 30, then we're going to move on to our P step. And I have a good flow sheet for this afterwards. We're going to do some review and we're going to do some questions here, and then I'll leave it up on the board so we can keep kind of going back to it. But if you guys want to write it down, you can, of course. Our P step is going to be for perfusion. So if we're up onto the P step, that means our patient is breathing and their respirations are under 30 breaths per minute. So we're going to check for a radial pulse. If our radial pulse is absent, it doesn't necessarily mean they're deceased. They could still have a carotid pulse. We're going to check their radial pulse. If it's absent, or if their cap refill is greater than 2 seconds or slow, they're going to be a red tag. It means something something's hindering their perfusion. If they don't have a radial pulse and they have a slow cap refill, likely they're not perfusing their brain very well. They probably got low blood pressure. They're going to be a red tag. If we get to this patient and they have a good radial pulse, we'll check their cap refill. If it's less than 2 seconds, then they get a nice little check next to perfusion, and we're going to move on to our M, which is going to be mental status. So mental status, if we've gotten to this area, that means our respirations are under 30, our cap refill is less than 2, and they do have a radial pulse. So we're gonna move on to our third step. So we're gonna ask them some simple commands. We're gonna just, hey, do you know where you are right now? Do you know what happened here? And maybe, do you know what month it is? Something easy, you know, if you ask them, you know, recite Pythagorean theorem, obviously that's not gonna work. So make sure they're easy questions, and also make sure they're questions that you know the answers to, okay? If they cannot follow simple commands, or if they have an altered LOC, or if they're just unconscious altogether, then they're gonna be a red tag. If they can follow simple commands, so this means respirations are under 30, perfusion is good, they have a fast cap refill, and it looks like they're alert and oriented, but they just haven't walked, or they got a broken leg or something, they're gonna be a yellow tag. So if you can get through RPMs and everything is good, then they're yellow. Nobody who's a green tag you should be going through your RPMs, because remember, all the green tags are gone. They're hanging out by the tree, or they're in the treatment area already. So everybody in here is at very least a yellow tag. So to determine that, we're gonna rev up our RPMs, as they say. It's just another easy way to try to remember this. If the patient is a red tag or immediate upon initial assessment, we can attempt to correct an airway blockage. You could do, you know, I don't usually condone doing finger sweeps, but you know, you could use you know, a NPA or something. I don't like sticking my fingers in somebody's mouth. You could control some major bleeding. If they're spurting blood from their femur, you could, you know, do a quick tourniquet or a wrap, but that's about it. We're doing very little treatment here. It's all about just triaging the patients. The only treatment you're going to be doing is if you come in on an ambulance and you're assigned that role to just start taking people, then you can treat people on the way to the hospital. If a patient loses pulses, they immediately become a black tag. Again, we're not treating them. If you have, let's say you have a red tag and you're taking them out and you're getting them packaged, and then the next thing you know they lose pulses, that's it, black tag, and we move on. Same thing with the yellow tag, same thing with the green tag. You come out to the green area and somebody's on the floor, we're gonna recheck them again. We're gonna rev up our RPMs again. If they have no pulse, black tag. So it can be, you know, we can change while we're doing triage. So again, when things get hectic with multiple patients, we're gonna rev up our RPMs. So always remember RPM, 32 can do. The respiration, the key number is 30, above or below. Perfusion is gonna be your 2, above or below 2 seconds for cap refill. And during our mental status evaluation, can do or can follow commands, alert and oriented. The START process permits a very few rescuers to rapidly triage a large amount of patients without any specialized training. There are even people who, I was reading an article